let's have a few housekeeping rules to begin with. Audio and video settings, please turn off your camera and mute your microphone. This webinar is being recorded, so if you don't want to be shown, please make sure to have your camera off. The presentations will be shared after the event, obviously with all the notes and everything taken out, as well as the link to the webinar. This is being recorded, as I mentioned. Questions and comments are, we are open for questions and comments all throughout the webinar. Please do put them in the chat at any point, and we're going to create a list of reserved questions to ask our audience, to ask our panelists. So the quicker you get it in, the better. Don't be shy. Please do ask questions. This is meant to be more of an interactive session. And then captions are available. Kindly click on more, then language and speech, where you'll find the option to turn on live captions. So with that, we embark on our mini medical series. Asthma affects over 9% of children and adolescents in the European Union, and its prevalence is closely linked to air quality, according to the European Environmental Agency. The same report found that in 2021, 97% of EU's urban population was exposed to PM2.5 concentrations exceeding WHO guidelines. In fact, air pollution remains the leading environmental health threat in Europe, contributing to at least 239,000 premature deaths annually due to exposure to PM2.5 above recommended limits. While policy discussions often center on outdoor air quality, indoor environments are often overlooked despite being equally critical. Europeans spend an average of 90% of their time indoors, where pollution levels can be 2 to 3 times higher than those recorded outside. Researchers also suggest that 1/3 of new asthma cases each year could be prevented if ambient air pollution were reduced to the lowest recorded levels in scientific literature. Given that Europeans spend the vast majority of their time indoors, improving indoor air quality could have an even greater impact on reducing respiratory health issues, particularly for children, than addressing outdoor air pollution alone. In this context, the Srebrenica Children's Hospital, a key EDIAQI partner, as well as the Synergy and EDIAQI projects, both members of the IDEAL cluster, are organizing the Breathe Easy, Safeguarding Children's Growing Lungs from Indoor Air Pollution, marking the inception of the mini EDIAQI medical series as part of the EDIAQI webinar series. We will explore today the current scientific understanding of how indoor air pollution affects lung function development and the onset of asthma in children, the most effective interventions to address childhood respiratory issues, should action be medical, policy-driven, or a combination of both, and ongoing European research on indoor air quality and children's respiratory health and how it can inform European policy. So with that, I'd like to firstly introduce our panelists for today. May I just kindly remind you to turn off your cameras unless you're participating in the webinar today. And joining us today for this timely discussion, I'm proud and honored to introduce our outstanding panel for today's latest installment in the EDIAQI webinar series and the inaugural mini medical series. Starting from left, we have Dr. Adnan Kuskovic, Professor of Pediatric Allergy at Imperial College London. Then we have Dr. Nikos Papadopoulos, Professor of Allergy and Pediatric Allergy, and Dr. Ivana Banek, leading researcher at Srebrenica Children's Hospital. So let me just give a quick run through of the agenda. Well, we just did the welcome and introduction, lung function as a critical indicator for advancing respiratory health across the life course with Adnan. Then we'll go to Nikos from evidence to action, roadmap and guidelines for healthcare professionals on improving indoor air quality for children. And then finally, we'll move to Ivana for breathing safely, insights from the Zagreb pilot on asthma, lung function, and indoor air quality. And then we'll go to a panel discussion, and then we have an interactive dialogue and questions from the audience. And then with some concluding remarks at the end, a little bit of marketing for you, if you will. Now we have our first Slido activity today. I would like to see who's in the room with us. With this webinar, we really are interested to see the kind of people who are participating today. And this is more of an interactive session. So if you could kindly either scan the QR code with your mobile phone or I'm going to be copying a link now into the chat, which you can use to interact. Please do interact. We really need your inputs and contributions. So just to see who's in the room, this will really support us as well to understanding how best to reach the community as well. So we have the first question. I see people are interacting here. Oh, John, could you kindly share the Slido? Thank you, John. So as you can see, 38% of the people in the room today are researchers or academics. Medical practitioners are 17%. Okay, of 12 people, we've got 14% now. Okay, let's see how high we can go. I'm going to leave it open for a little bit. Oh, this is great. We keep going up, 19%. I'll have some maths to do at the end to figure out exactly what that means with the full numbers. Okay, 18. Let's see if we can make it to 20. But okay, as we can see, it's quite evenly split. We have a few policymakers in the room, a few public health professionals, not so many teacher, educators, or school staff, as I can see, a number of medical practitioners, but mostly researchers and academics, with 23 counting. Okay, we're going to leave it here for just another minute, and then I'm going to invite, and you can keep answering this, and then I will invite Adnan to share his presentation. Okay, so just one more minute. Adnan, please do go ahead and share the presentation. The floor is yours.
Thanks very much, Alex. I believe you will see my presentation. I'll just give you a little overview of the importance of lung function as a key indicator, not only respiratory, but of general health. These are the context within which I would like to talk is, think of a lung as a developing organ, and its development starts very early in the first trimester of pregnancy. The problem is, by the time you're born, the lungs and the airways are not fully developed. They continue to grow and mature during first 2.5 decades of life, reaching the peak of lung function in early adulthood. After that, you have a decline due to aging until death, basically. Now, the developing lung is really susceptible to a whole range of adverse environmental exposures, and this can potentially lead to a decline in lung function. If you turn it upside down, conversely, during this developmental phase, you can also impact upon the recovery from these adverse prenatal and early life exposures. Ultimately, the message is early life events are absolutely critical for lifelong health and lung health. And if we're really serious about prevention of adult disease, it's far too late to think about it in adult life. Now, this is the conceptual framework of lung function trajectories from preschool age all the way to the adult. This is kind of really a lovely summary of all of the findings that we have today. And now we describe trajectories of high lung function, average lung function, low, with some lung function trajectories associated with failure or potentially catch up. Now, the conceptual framework is that lung function tracks from childhood into adulthood. And this is interesting because you would think, well, if it tracks those individuals with poor lung function in childhood, then would end up with poor lung function in adulthood, and there's precious little we can do about it. Now, importantly, so this was the framework within which we worked up until 3-4 weeks ago. This is tremendously important, really interesting study by our collaborators in European Respiratory Society, CAPSET collaboration. This was done by Judith Garcia, our marriage. Really interesting sort of accelerated cohort study, pulling together a number of cohorts with longitudinal lung function with overlapping ages, and utilizing very, very interesting, sophisticated modeling techniques to look at what is actually going through life course. Now, what is really interesting is that this is the first study to suggest that increase in lung function during childhood all the way to the adolescence is not linear, but actually happens in 2 phases. You have very first early childhood growth, and then somewhat slower growth between ages 13 and 16, really indicating at which point you can make the most of an impact. There is no lag period, so no phase within which there's little or no increase in these parameters. Interestingly, lung function is slightly earlier in females than in males by about 3 years, and there is no really kind of plateau. The moment you reach the peak, you start decreasing, and this decrease is about 20 to 40 milliliters per year. The decrease then varies through life course depending on age and sex. And what I suggested here is that surely spirometry, measurement of lung function, should be utilized early in life to pinpoint, to identify those individuals who are at risk of adult chronic respiratory disease. Now, why is that important? Well, the critical importance of this is you would expect that impaired lung function at physiological peak predicts respiratory health thereafter. This is a fantastic study by Alvaro Agusti, measuring lung function at physiological peak in third decade of life and then following these individuals through life course. Actually, impaired lung function when you're in your 20s is associated with much higher prevalence, yes, of respiratory, but also of cardiovascular, metabolic abnormalities, and multimorbidity. So this is independent but additive to the cumulative smoking exposure, for example. So lung function measured in third decade of life is key indicator of health to come. This is another fantastic study. 15,000 individuals measured lung function and then followed for more than 25 years, now looking at sudden cardiac death. And what is crystal clear is that those with impaired lung function are much more likely to die early of cardiac death. So there is tremendous potential of lung function measured at right times to identify those individuals who are at risk. And this led to our proposal last year that, similar to what we do in pediatrics by measuring children's height and weight, their growth regularly to identify whether there are any problems and intervene, we put forward the idea that similar to these pediatric anthropometry charts, we should measure lung function from childhood to capture the development of lung function and identify those individuals who may be at poor risk who may be at high risk of poor health. We also provided a free online lung function tracker tool in which people can put in the levels and then monitor this at individual level to identify whether there are any deviation from this. So measuring lung function early can identify those individuals who are at risk, which is great. But telling somebody you're at risk without having something actionable, something that we could do to modify this risk, is not really what I would like to do in clinical practice. So when you look at trajectories, this idea that, you track from childhood in adulthood gives you an impression that there's little you can do. So the key question here is actually how fixed are lung function trajectories? And this is key just a couple of months ago, using vast number of data in longitudinally measured spirometry through childhood in 6 European birth cohort studies, which identified for the first time using machine learning and AI different trajectories that are associated with change. Okay, most people have normal lung function. There are approximately 15% with impaired lung function. There are 2 small trajectories characterized by decline and improvement in lung function. And these are substantial declines and improvements, about 15%. So can we do something? Can we identify associates of the change in order to implement strategies to change lung function? Modeling the development of lung function through life course suggests that improvement in lung function through childhood from sort of early school age, mid-school age, early adulthood, improvement is more likely from middle childhood to adolescence, while worsening is more likely between adolescence and early childhood, suggesting that cumulative exposure to adverse environmental factors may really adversely impact health. And then you can ask question, well, what are the associates or factors which impact on improvement and decline? And it's very interesting. You can then dig into really sort of personalized intervention that you can say, this is really interesting interaction between obesity and asthma, in that it clearly demonstrates that asthmatics who are also obese are at high risk of decline and they do not improve. In a marked contrast amongst non-asthmatics, it is underweight that is associated with loss in lung function. So, simple message for you, tackling overweight and obesity amongst kids with wheeze and asthma, and underweight in skinny non-wheezers may help preserve their lung function and then reduce subsequent morbidity. If you go even further into early childhood, this is a study that we did in South Africa with measures of lung function from 6 weeks, 1 month, 1 year, 2 years, 3 years, to age 5 years. It is a series of various environmental influences from preterm birth, postnatal smoking exposure, lower respiratory tract infections, or interaction of those that impact development of lung function in the first 5 years of life. And there's multiple harmful impacts of these exposures who have additive effects. And interestingly, all of these are associated with deprivation. So what I'm putting to you is we really need to make change to our practice. We should start measuring spirometry. In a similar way we measure height and weight. When children start going to school, to identify high-risk groups, and these high-risk groups should be treated for health interventions. It is tragedy that in 21st century, all the markers of childhood deprivation are associated with persistently poor trajectory of lung growth, and it puts them really sort of at risk. It makes them more susceptible to all later insults like indoor air pollution and outdoor air pollution. More rapid lung function decline, COPD risks. It increases all sorts of adverse health outcomes, early aging and early death. And this is all sort of wrapped up in the transgenerational effect of these environmental exposures. This is what we need to break. We need to break this transgenerational cycle of deprivation to prevent transmission of early lung disease and morbidity. We cannot even start in international clinics. We have to start before. So political action is essential. Now you may say, well, we should wait for political action. No, we shouldn't wait for political action. We should act now. But political action makes difference. This is a lovely example in relation to outdoor pollution in California. You know, 3 cohorts from 90s, early 2000s, and end of 2010, 5 communities, you know, with improvement in air quality, which was associated with legislation, you had marked improvement in lung function. So things can be done. And with that, I leave it to Nikos to talk about all of the factors in the indoor environment that are associated with these adverse exposures that can lead to poor health and subsequent risk of all sorts of multimorbidities. Thanks very much.
Thank you, Adnan, for that real look at a very interesting look at the whole life function cycle. It's very interesting to think about how we can use that to understand maybe medical trajectories of people. It does scare me a little bit that you said it all goes downhill after we reach adulthood, but I will try to ignore that fact. So with that, Nikos, I hand over the floor to you. Please take it away.
Thank you very much. So you can hear me, you can see my slides, everything is fine. Okay, great. And you know, I'm always inspired by Adnan's talks, and this has been a particularly inspiring talk and also particularly inspiring findings and suggestions. There are things that we realize actually, perhaps we knew already, and there is a big challenge to bring these things into everyday life, to actually change something so that we can achieve what we can achieve. And this is about policy, not only governmental policy, but it can be personal policy, it can be regional, local policy, etc. So what we know, actually, we know that pollution has really many different effects on health. This is a very complicated issue because you have direct effects of pollution, and of course you have the direct effects on the main pollution, which is the respiratory system, but also the skin, the gut as a next level. And then you have secondary effects that can be very complex. They can lead to chronic diseases, or they can lead to cancer, they can lead to conditions much later on. However, I think it's important to realize that in many cases, as we have heard before, when it comes to lung function, when it comes to respiratory, actually the effects, the acute effects on one organ can be correlated and can predict the overall effects on health. So it is important to understand that the pollution effects on health is very complex, but we can identify conditions like asthma or allergies, people that are hyper responsive, and then actually find what the minimum, let's say, effect that, or the minimum pollution that would have a health effect. Then the second question on that, of course, is which pollution. And when we talk to pollution, most of the times we're thinking about chemical pollution. We're thinking about the smog. However, we know very well that for a big proportion of the population that is allergic, that's sensitized to, for example, pollen, as you can see here, this is a cloud of pollen, the allergens are actually pollutants themselves. They are biological pollutants. And the same thing happens with viruses. Viruses are actually a little bit different because in many cases they can be harmful only, but in other cases it seems that when you look at it from the microbiome or the viral perspective, they might not be harmful as well. They might also have a beneficial effect. However, we need to admit that we have both chemical pollutants but also biological pollutants. This increases complexity. So in order to act, we need to understand where these pollutants come from, and of course how we can act in each of these different sources. And you can find pollutants for indoors or outdoors, coming from indoors or outdoors. You can have pollutants, for example, from cleaning agents, or you can have pollutants from paints, you can have pollutants from individuals being together, a lot of them in the same room, etc. But also you have a lot of pollution that is used by industry, etc., etc. And it has been mentioned already that a very big proportion of time we spend, not only Europeans, but actually the majority of people in this world, we spend it indoors. And this proportion can be from 60-70% up to 90%. And I will show you here on the right, there are some of the first results from the Synergy project, where you have on the left two columns, you have a correlation between different types of pollutants. I'm not going to go into each of them, but there are different types of pollutants, which are indoors on the left or outdoors on the right at the same time. And as you can see, so the more intense is the color, the stronger is the correlation with the health of children in schools that we follow up. So you see that the correlation between pollution, different pollutants, and health is much stronger with concentration of pollutants indoors than it is outdoors. But of course, when we're talking about policy and translating these findings into some kind of policy, we need to realize that policies are also quite complex, and there are different levels of policies. So at the EU level, we have different policies that can be associated or are associated one way or the other with what we're talking about. And of course, we have different environmental policies. We have climate-related policies, which are directly related to air pollution and health. We have policies around chemicals, policies around buildings, and of course, central here are the different health policies. And these are the ones that we are concentrating on because our audience, because people who with which we discuss and we transmit the knowledge to are on the health sector, either academics or medical practitioners. But still, on this health policies, there are many different stakeholders, and we need to recognize that each stakeholder looks at the problem of the challenge from a different perspective, from the policymakers at the different levels. And this is something that we are systematically addressing in Synergy, trying to identify or making a database, a list of the stakeholders that can be interested so that information is transmitted. Or, for example, industry on the other side, construction, and centrally here as well is healthcare. But what can health professionals do? And that's really very simple and straightforward. The first thing that health professionals can do is be aware of the issue and the different aspects, as many as they can. People need to be aware of lung function trajectories, for example. People need to be aware that allergens and viruses can be pollutants and they can synergize with chemical pollutants in inducing respiratory problems, etc., etc. So this awareness is actually what we're doing now and what the different projects are doing so that we can start from there for the next step. In conditions, for example, like asthma, it is very important to include the concept of exposure to different pollutants in the monitoring plans. We know that each time a child or a person actually goes to see their doctor, they will ask them about the symptoms, they will ask them about many factors. Not always they will ask them and they will realize about the different exposures, particularly the irritant exposures. So I think it has to be specifically included, and that's a medical advice that looking for exposures is something that needs to be included in the monitoring plans. And then try to be proactive, both in sensing and air cleaning. And both of these have their own challenges. We need to understand, first of all, whenever I do a talk in a closed room, I ask people, do you have any idea of what are the levels of CO2 in this room? And if you feel sleepy, are you sure it's the speaker that's boring, or is the fact that you have very high levels of CO2 at that moment? And this induces sleepiness anyway. And then, of course, if you do know what are the levels of different pollutants, what can you do? How can you clean it? So the roadmap, in order to reach, say, a better state of a cleaner air and improve indoor air quality, both for the children that we're focusing on, but also for everybody, has many different steps. First of all, we need to identify or create or help with the development of reliable low-cost sensors. And this is quite challenging. And I found out while I started doing this Synergy project, because I thought, okay, you can take a device and then you can measure the air quality. This is not exactly true, actually. It's quite challenging to have an accurate and low-cost sensor at the same time. Then we need to identify or define or agree on what are the most important health outcomes. And yes, lung function is a very important health outcome. And there are many other health outcomes that we need to be aware of. Then we need to understand the pollution dynamics, which means that if you're in a room, actually, if you're closer to the window or if you're further away, or depending on how the space that you're in, then you are exposed to different levels of pollution. It needs to be taken into account. And of course, we also need to have models, in vitro models, to tell us what are the interactions between the different pollutants. And we need to understand, because all these pollutants have additive or synergistic effects, and we don't understand these effects very well. Then, of course, if you want to sense many different things, you can't have too many different devices. You need to integrate this sensing in a solution that will actually understand what's happening in the environment and then give you, based on a cloud or on an AI or an analysis basis, it will give you the advice. And this advice can be included in the standards and, of course, in the health-based guidelines, which we are going to be producing with Synergy and with the other projects of the ideal clusters. Based on these ideas, on these guidelines, on the consolidation of these researches, then the policymakers will be doing the policies, and we are already starting. It's not only the policymakers, as I mentioned, it's also us trying to communicate and disseminate the ideas. This is just an example of things that we're doing within Synergy. This is a box that contains a couple of, actually several different sensors. The one on top is a pollen sensor. The one down there is a chemical sensor for many sensors. There is also, in the future, in the next iteration, we're going to have a virus sensor as well. And here on the right, You have a green wall. It's an example of a type of a filter, which is also very nice to see, and it generates a good effect. We are actually studying how effective these will be on the health of school children indoors in schools. And of course, this is something that Synergy does, but all the other projects of the Ideal Cluster, they have the same direction. It's really important that there is this collaboration, as we have now with EDIAQI, to join forces in order to do the awareness, the communication, and the discovery as well. And with that, I would like to thank you for the attention.
Thank you so much, Nikos, for that surgical dissection from a medical perspective of the Synergy project. It did scare me a little bit seeing that massive cloud of pollen that you demonstrate. I almost wanted to sneeze on seeing that, but very interesting work that you're doing here. Now we'll turn obviously to a project that's very dear to me, to the EDIAQI project, where we'll learn a little bit about the child cohort that we're studying as part of the EDIAQI project. And that is my colleague Ivana, who's joining us. I will just need 2 seconds to reload the presentation, and we'll begin. Ivana, the floor is yours. Please do come in.
Hi, everyone. Thank you, Alex, for the lovely introduction. Right. Can you see my presentation?
I've shared the presentation. You'll just need to tell me next slide, Ivana.
Okay, sure. I'll just give you a few of the insights from our Zagreb pilot within the EDIAQI project. This is the only pilot among the 4 pilots that involves human participants, and it is a clinical study. So you can skip to the 3rd slide, if you will. Okay. So Adnan and Nikos have given us a lovely introduction on the presumable health effects of indoor air quality on human health. I'm just going to give you a few bullet points that might emphasize the importance of indoor air quality. So it is thought that people spend up to 90% of their time indoors as a modern way of living. Indoor air pollution, including biological contaminants such as pollen and mold, can elevate the risk of developing respiratory diseases by up to 50%. Up to 400 premature deaths are accounted annually in Europe and associated with air pollution. And indoor air pollution claims up to 237,000 childhood deaths annually, so up to 3 million deaths totally, and of that 237 childhood deaths. There's also been noted a dose-dependent relationship of particulate matter and asthma symptoms. For every increase in concentrations of fine particulate matter of 10 micrograms per cubic meter, there has been a 6% increase in the number of days with asthma symptoms, a 7% increase in days with more severe wheezing symptoms, and a 4% increase in days using reliever medication. So these are some serious data here. Okay, you can skip to the next slide. The EDIAQI human biomonitoring concept consists of 2 levels. So first, we utilized some retrospective data from previous cohorts, such as the FB7 atopica and the COPSAC, the well-known COPSAC 2010 cohorts. We used this data to reanalyze it using novel machine learning algorithms in order to identify key indoor air pollutants and key factors that might contribute to disease and health. And we use that to construct our prospective cohort, which is the Srebrenic Children's Hospital 2021 cohort within the Zagreb pilot. We use this to understand the relationship of health effects and indoor air pollution, to map biological contaminants in indoor air and in bed dust, and also to characterize these pollutants and their concentrations indoor, so inside of the participants' homes, versus outdoors. So we use sensors both indoors and outdoors. So the retrospective data analysis revealed that an association was found with dust mite sensitization and mattress agent use of certain types of heating within homes. Also, the use of fossil fuel as a source of heating was associated with wheezing in children, and the concentration of inhaled allergens and time spent indoors in kindergartens was associated with eczema in our atopic cohort. Within the COPSAC 2010 cohort, associations were found between indoor air quality and certain sources of pollution, such as carpets, cooker hoods, fireplaces, heating sources, etc., and selected metabolites in their metabolomic study. So what the Zagreb pilot focuses on, it is an observational case control study. We are doing indoor air quality measurements in real time, so within the homes of our participants. We are collecting a large number of clinical, biological, and indoor air quality data. And we also have quite a number of biological samples. So we have blood from the participants, their buccal swabs, exhaled breath condensates, and peripheral blood mononuclear cells. So the Zagreb pilot is located within the capital of Croatia, and it's suburbia. It takes place in the households of the study participants. So there were over 120 individual measurements in the households of the participants to date. So we are analyzing microbial diversity in the house dust and bed dust of these participants, and clinical assessments focused mainly on asthma and allergic diseases is being done at the Srbinjak Children's Hospital. The study participants are school children aged 6 to 18 years, and we have recruited 206 of these participants so far. These are patients with asthma and other allergic diseases versus non-allergic controls, so cases and controls. And what we're doing is baseline clinical assessments at the point of recruitment. We're also doing transcriptomics, so we're going to be doing non-coding RNA studies, and we're also doing genomic instability assessments at baseline in parallel with the indoor air quality measurements. These measurements are 3 to 7 days long on average, but certain measurements are being done for a longer period of time, such as those households selected for radon measurements will have radon measured for approximately 3 months, and fine particulate matter measurements will be done for approximately 1 month. The participants will be followed up clinically approximately every 6 months for a period of 2 years. And why we're doing this is to collect data to reflect real-life scenarios on indoor air quality in people's households, on real participants and vulnerable populations, of course, children and chronic and people with chronic diseases are considered vulnerable populations because they're more susceptible to the health effects of indoor air quality. We're also doing measurements of daily fluctuations of indoor air pollutants in the households of the participants. So we have sensors that measure the fluctuations of these pollutants on a daily basis, and we are building complex prediction models of the health effects of these indoor air pollutants. So on this map, you can see that locations of the households in which the measurements have been undertaken. There's a really good distribution throughout the city of Zagreb and its suburbia. And on the left, you can see the actual measurements, average measurements of polycyclic aromatic hydrocarbons in the actual households. Of these, 2 have been selected for in vitro and in vivo experiments, which are currently ongoing. So these are benzofluoroanthane and benzoglyperylene. So some of the preliminary results that we have also done. So the microbiome sequencing has been done, and we have compared the microbial community composition in the Danish and the Croatian cohort. These differ significantly, which is quite interesting. And we also have preliminary results that indicate that microbial diversity is significantly associated with asthma and allergic diseases. That is, the lack of microbial diversity is associated with asthma and allergic diseases. So I'm going to show you, Alex, can you please click on the link in the next slide? This is a visualization of the measurements results within individual households. This is still being polished, so please, this is just like a beta version. You can see that we've created certain star plots and other scatter plots and other. The username and the passwords are the same, so it's ID_1.
We are just logging in now, so if you just bear with us just one second.
Sure.
We have a little bit of time. John, if you'd be so kind.
So this is actually, we initially thought to design this to be as user-friendly as possible to the participants who are of different backgrounds. So not many of them are of scientific backgrounds. So we want to create a visualization tool for them to see what the actual measurements in their households are. So since there are not a lot of guidelines and reference values for different pollutants that are being measured within the Zagreb pilot, we thought a star plot or a mean or a plot that shows means of measured pollutants against the average of the other households within the pilot measured is going to be a nice representation for the participants. We're also including a little wiki in here in the detailed explanation. So just a few notes for the participants so they can know what different pollutants mean, what their presumable health effects are, and try to visualize this for the participants in a lane language. This is just being still polished, and all of the participants will have their username, individual username and password, and they're going to be able to see their measurements in real time.
Ivana, could you kindly share the login, please, and so we can share the login?
I'll just write it in the chat.
Thank you. Or would you like to share your screen, maybe?
Sure, if that's okay with you.
Yeah, of course, of course. Please go ahead.
Okay, can you see my screen?
We can see your screen. We can see your screen.
Oh, sure.
Now it's all making sense. That very nice explanation.
I've just been talking. No one can see what I'm actually talking about. Okay. So this is the star plot of the individual concentrations in a certain household against the mean of other households within the Zagreb pilot. So you can see which pollutants stand out in your individual household. And also the detailed explanation gives a little bit of information in lane language for the participants, what certain pollutants are and what their presumable health effects might be. And I'm going to stop sharing now, if that's okay with you.
That's okay with me.
And with this, I will end my presentation. There's a lot of work still being done within the work package 5 of the Zagreb pilots. So we will have quite interesting results very soon. And this will be a topic perhaps for another webinar. But for now, this is just a little teaser of what the Zagreb pilots is focused on. So thank you very much for your attention, and all questions and remarks are more than welcome in the panel discussion.
Thank you so much for that look. It's really interesting to see the work in detail that we're doing in the Zagreb pilot. I think one of the interesting things that you've said is this maybe intersectionality, right? That you're talking about children who are already a vulnerable group, and then we're adding the fact that they have a chronic disease, right? A chronic issue, so health issues. So I think that was a very interesting look and something that I've never really considered before. So thank you very much for that point as well, Ivana. Okay, we're going to head to the panel discussion portion now. I invite all of our speakers to please leave your cameras on for the discussion. We have the questions to make it easier for you. We'll go in the order that we started. First, we turn back to you, Adnan. So you gave us this really nice introduction to how the lung function trajectory can be a real health marker for people. So how significant is the lung function as an overall health marker beyond respiratory diseases, particularly cardiovascular and metabolic health?
I mean, it is crystal clear that a measurement that is relatively simple and straightforward, like spirometry, can be utilized as really good indicator of overall health. I'm not talking about respiratory health. You've seen the data. Premature death of all causes, death of cardiac causes, association with metabolic diseases and multimorbidity. These are all tremendously important health outcomes, and there's a simple indicator that you can pick up early. I mean, we've shown that there is really interesting association between echocardiograph in healthy individuals at industrial scale, 6,000 individuals measured when they were healthy, and their lung function. In that lung function really is associated with all of these indicators in echocardiogram that predict subsequent cardiac disease, but also stroke. So I would put to you, it's much easier to do simple spirometry within minutes than to do echo as a screening tool. So fantastic screening tool to identify individuals at risk. We have to utilize them.
So maybe there's a big call here for the spirometer. I know that we're using it in EDIAQI quite significantly as well. And it was very interesting, the paper you shared as well there. Thank you very much, Adnan. Okay, so now building on what Adnan has said, we're going to head to Nikos here. How do multi-pollutant exposures? So we've moved so from the general, from the lung function now to specific localities, specific microenvironments. How do multi-pollutant exposures in schools and homes contribute to childhood asthma and other respiratory conditions?
Yeah, it's a nice but a general question, and it follows on from the previous one, and trying to look at things on a kind of wider scale. You cannot have, let's say, a healthy lung and a diseased heart. It's very difficult actually when you exercise to actually exercise only for the lungs but not for the heart, or only for the heart but not for the lungs. So this is why you can have one thing as a reference and do it easier. And when it comes to exposures, this can be a little bit different, because one exposure, one pollutant can be much more toxic, let's say, than another. And when you have two or more, these can interact between themselves. And we've seen that in some occasions, like, for example, in thunderstorm asthma, where you have, let's say, different elements that, or the weather, for example, and the allergen that interact, and they generate a much larger effect. Now, when we're talking about exposures and asthma, then we need to realize that you have two things. One is at the beginning of life, usually, when you develop asthma, when you didn't have it before. And then you have the expression of asthma, if you do have asthma, the exacerbation and everything else. So this is not necessarily exactly the same. However, in order to put it on general terms, we know that each hit you get generates an impact, harms your body to some extent, and then you need to repair the wound. If you get lots of hits, then repairing the wound can be quite difficult. This is why the multi-pollutant effect is really important. And of course, when you go to susceptible individuals, and these are children, these are people who have hyper responsiveness, like children with asthma or allergies, then you have an even stronger effect. And of course, it's. I mean, I could talk for a long period, but I think how I covered.
No, you were very comprehensive and concise, so I always thank the panelists when they're comprehensive and concise as well. No, and I think it's very interesting, this noxious synergies, right, which is the name of the project at the end of the day, is looking at these noxious synergies, so not just understanding them independently, but understanding them collectively as well, which I hope as a shared mission, we're doing very well together. Now we'll turn to Ivana to take a look at more on the ground kind of work with a specific cohort. So, Ivana, how does the Zagreb pilot, and apologies for the bit of the space there, how does the Zagreb pilot contribute to the understanding the relationship between indoor and outdoor air pollution and asthma development in children?
Okay, so as I've elaborated in my presentation, so we are measuring both indoor and outdoor quality. So we have devices and sensors installed within the households of the participants, measuring both indoor and outdoor air and the fluctuations and their interrelationship. We have cases of participants with asthma and allergic diseases and controls, so non-allergic and non-asthmatic controls within the clinical study. And we are now analyzing this data that we have collected to see whether certain indoor air pollutants or their binary or complex mixtures and their distinct patterns may influence disease versus health. So we're trying to see whether these any of these pollutants or their mixtures or patterns are associated with respiratory diseases. This is going to take some time, but that's the end goal. That's the end goal of the EDIAQI Zagreb pilot.
Thank you, Ivana, for that. I'm very hopeful about it. I think we're going to get some very interesting data from that can hopefully feed into the broader outputs of the Ideal Cluster and the EDIAQI project as well. We'll bring it now back to Adnan, looking at now the specific groups. We started talking about the childhood cohort in Zagreb. Now let's move it back to a bit of the higher level here. So are there specific population groups, such as children in urban areas and those exposed to high indoor pollution, who would benefit most from routine lung function monitoring? So circling back to the lung function monitoring. Please, Adnan, take it away.
Lung function monitoring should really be done routinely across population. This is tremendously important. It can identify individuals at risk. But if you think about it in more broader terms, it can also identify clusters of impaired lung function at the level of population. You know, it's very easy to say, well, we think these children will be exposed to high indoor air pollution, where you don't know until you go and measure it. And Nikos has highlighted beautifully how difficult it is. So identifying clusters of impaired lung function at population level is really, really important, because then you really sort of have an indication that there is something going on within that particular population, and then you can probe it by either going very aggressively in terms of monitoring of the outdoor pollution, going into their home, assessing their indoor pollution. It is very interesting that, you know, work in Africa has suggested this complete disconnect between the health effects of indoor and outdoor air pollution, different markers like symptoms and lung function. So not only that you can identify those individuals at potential risk and intervene, but also that can help you identify clusters of impaired lung function and then subgroups within population that may be at risk. And then you can go with public health measures.
I really like that. It's very interesting. So maybe in a sense, it's a marker for a population that's particularly susceptible. One of the interesting things is that you mentioned Africa as well, because if you look at all of the studies, they often mention there's a gender dimension to it, right? Because very often it's the women and girls who are doing the cooking and the cleaning and who are more exposed to indoor. So maybe there's also a marker for population groups as well. I don't know. This is just a thought that you inspired me on there, Adnan. Okay, we'll bring it now to Nikos. Oopsie, I've jumped one over. Apologies there. So we've kind of taken a look at how the lung function could be a marker for identifying clusters. So what are the most effective interventions identified so far for improving indoor air quality, specifically in schools and childcare settings, which is a big focus of the Synergy project?
Well, yeah, so you expect me to tell you the solution, yes, and I will. But before doing that, I think, as you've been discussing before, it needs to be personalized. It needs to be much more precise. We need to understand that not everybody is the same, and there are different needs there. Having said that, the most effective measure to improve air quality is to ventilate. Open the windows. And that works very well in the majority. So in the Western world, in some of the cities or suburbia that we get our data from, there you actually have really a good effect just by opening the windows. You don't need anything more. Of course, as I say, you cannot generalize, because if outside the window you have an industry, then you have to think about measures, or you have to try to be more precise, for example, at the time level, because we have found that at the time in the morning when the parents bring children to home and they bring them with cars in Athens, then the levels of pollution around the school are increased very high. At that time, you shouldn't ventilate inside the room. You should keep the windows closed. So these are the personalization in a way. Then the second thing one can do is filtering. And air filters, they come in many different types and sizes, etc. But generally filtering is about particles. So basically, if you want to target particles is one part of the problem. It's an important part of the problem, and you can remove particles to a good extent with different types of filters. But I will conclude that I think a very, very important intervention is being aware and sensing. So if you have a little sensor inside the classroom, inside your house, and tells you that, at the moment you have fire or what type of air quality you have, then it urges you to do something. And I think this can be stronger than all the previous at the moment.
Thank you for that really strong message of awareness. We are really obviously trying with this EDIAQI webinar series, which is always done with an ideal cluster member, I might add, to kind of raise that awareness, and these stick and stay. So we see that as something very, very important as well from our perspective. And it's interesting, as I was just at yesterday at the Ideal Cluster colloquium that they organized on the margins of the Aerosol, the final event. And they were actually talking about in Barcelona, for example, the spikes in pollution levels during these peak commute times, right? And that maybe there's a fallacy that if you open the window at that time, that you might actually be getting worse air quality as well. And I will add maybe one more thing. There's also a link, I think, and this is a hypothesis, I mean, it still needs to be proven, obviously, between urban social economic inequalities and probably pollution levels within those areas as well, right? Residences tend to be located in localities that are either transport nodes or industrial hubs, etc., etc. Now we'll bring it back to the ground level again to Ivana. Ivana, so now from your work, from your research with the child cohort in Zagreb child cohort, what policy recommendations could emerge from this research to improve indoor air quality management in Europe and beyond?
Well, yes, as Nico said, policy making is quite often complex. It does have to rely heavily on research and evidence driven from interdisciplinary research. So I believe that the Zagreb pilot employs such an interdisciplinary approach. And we do believe that the results from the Zagreb pilot might lay ground for certain policy making. So not perhaps in individual pollutant levels or guidelines or reference values for individual pollutants, but rather for their complex mixes or patterns of different indoor air pollutants, especially for their interrelationship with outdoor or ambient air, and also for guidelines for preventive strategies in asthma and allergic diseases, which are one of the main focus in these in the management plans of these conditions. So you can't have effective management of these conditions without effective prevention strategies. And I do believe that some of the results from the Zagreb pilot might influence these guidelines and these policies around these complex presentations or complex patterns of indoor air pollutants and allergic diseases and asthma.
That strong call for scientific evidence to inform policy, to make sure that policies are informed by scientific, I think it's really critical. It's very important, that complex argument, I think, as well. I think one of the things from Nikos's presentation that was really strong is he showed the complexity of it, how it's so cross-cutting, right? How many different policies did you show there where indoor air quality was a component, right? Or something that we needed to consider. And I mean, I always, obviously we're working in the Ideal Cluster Working Group 1 and the Joint Policy Brief. I think a strong recommendation would be something like one specific EU level policy that addresses indoor air quality rather than being strung along in a sort of different patchwork. But it is cross-cutting, right? So I think that's an important point. Okay, thank you so much for the panel discussion. Now we have a lot of reserve of questions to ask you. Before that, we want to do a little bit of interactivity with the audience, some engagement with the audience. If you would be so kind, again, I'm going to share the link in the chat. John, could you share the presentation? I'm copying the link into the chat. Please do participate. So we're back still at the first question. If you haven't answered it, we would really appreciate just the opportunity to answer this question so we can gauge who is our audience today, because specifically we'd love to reach medical practitioners. We can see we are very represented by researchers and academics today. I'm seeing that the numbers are going up. We're going to give it 3 more seconds. Oh, they're going up. They're going up. Okay, perfect, perfect. So we'll give it 1 more second, and then we're going to move on to our next question. Okay, we got to got to 28. Proud of that. Got to 28. So, have you ever used a lung function tool in your life with children, and how regularly? This is particularly for the medical practitioners in the room, but also if you were a patient and you used it. Let's see, no answers yet. Okay, 2. We're going up. 5. Okay. Yes, regularly. Never. Yes, once or twice. So it's either never or regularly. So there's nothing in between, apparently. Okay. Very, very good. We'll wait to see if we get to around 25. And then, okay, we'll give it a few more seconds. Okay, I think that's the number of answers and responses we're going to get back from this question. Ooh, 17. Can I move ahead? Okay. I think we'll move now. So
by the way, if I may intervene, the use of a peak flow meter is very specific. So, and I mean, if you don't use it properly, it's better not to use it. So, yeah.
Thank you for I have to be. I'm not a medical practitioner or technical person, so I thought about these questions with the concept now, and I'm sure they're a little bit. So no, I think it's an important point as well. So actually, I ask you, my panelists, as well, maybe to answer these questions as well, but you could do it. So maybe one by one. Adnan, do you think, which of the settings do you think should get a priority for indoor air quality improvements?
I mean, there's real question mark as to whether you can concentrate on a single sort of source of exposure and hope that you will make a difference. Given the complexity, you really need to address this issue systematically. So, I accept that any improvement is the step in the right direction, but I'm afraid that by saying, oh, we'll focus on schools, something else will drop off. So yeah, I'm a great believer that everybody has right to breathe in clean air.
If I may intervene, sorry, if I may intervene in this one as well, I think it's important to realize that the stakeholders and the regulators are different for each of these spaces. So if you want to improve classrooms, then you go to the Ministry of Education. If you want to improve medical settings, then you go to the Ministry of Health. If you want to improve your bedroom, do it yourself. And that's really important to realize, and you don't expect anybody else to improve your bedroom.
I like that point as well. It's very important. We can take ownership. Like, we have agency over the spaces that we own, right? And that we own, or that we reside in, right? To a certain extent. So I think it's a very important point that, and Ivana?
Yeah, but also I think we should perhaps take baby steps, because policy making, as Nikos said, is a very complex procedure. And we can't change it all at once, not even partially. So we can take like baby steps. Of course, everyone has the right to decide what they do within their home. And I know a number of people already have filtration devices, air cleaners, etc. But I believe we do have certain pilots within our country and our city that are unrelated to EDIAQI. And I just found out this information because I talked to these people, and they were quite excited and quite surprised of the work that we are doing within EDIAQI and the Ideal Cluster. But these are like private settings, private daycare centers, private school, etc., that have already employed these filtration systems and devices as a selective advantage to offer to the parents and to the participants that go to these institutions. So they are doing their own mini research and mini testing of these devices, and we're going to see in a few years, maybe in 1 or 2 years, what their findings will be. Of course, these are not structured. This is not structured research. These are not structured studies. But yeah, there is, I think there is movement and there is interest from the public to employ this kind of approach. And it's always more flexible to work with private institutions rather than the public settings, where you have to involve different levels of policymakers and different levels of authorities. But yeah, baby steps, taking it there one step.
And you also said multi-pronged as well, which I like. Yeah. Multi-pronged. So we're saying also maybe we need to go to the private sector. They might be easier. Very, very important points there. So moving on to our next question, and maybe we'll skip one of the questions. What is the biggest obstacle you face when trying to improve indoor air quality in 1 or 2 words? So maybe for Ivana and Nikos, it's policy. Maybe I'm adding that there. Maybe I'm right. I don't know. So if you had to choose one word, we'll start from Ivana and we'll go the other way this time. What would be the 1 or 2 words?
Well, if you ask me, then yes, policy administration. That's the biggest obstacle, I believe, in my country, definitely, but I think it's quite similar in the EU. So yes, policy and authorities, these are the hardest 2 obstacles to deal with. Yeah. To implement any scientific data, any scientific evidence within, a routine daily practice, you need to tackle a lot of administration.
And Nikos?
Well, I just put down blurry knowledge because we are all aware that, pollution is bad, but from pollution is bad to which exact element is bad and which paint to use is, you need to do, many important steps. And I remember an example. A friend of mine has a school, and they were doing creative stuff with her kids drawing. And, they asked me whether, the markers that they're doing the drawing should be of some particular sort in order to avoid, contaminating the air. I didn't know what type of markers you should actually use, what type of pencils and all that. We know that you shouldn't use chalk, but there are so many details. So I think we need to improve the knowledge and the understanding.
I think it's a very strong point as well. I mean, today, for example, there were so many elements that were very new to me after you've been working on this for a number of years now. And it's something that's really cross-cutting and dynamic, right? And maybe it's a pool of knowledge that we really need. So maybe that's the heart of the ideal cluster as well. Adnan.
I mean, I totally agree with Nikos. So, when you look at outdoor air pollution is much easier to handle with in terms of communication. It's visible. People can see it, people can smell it, people can feel it. There are interventions that can be taken to impact it. Exactly what would be the legislation? Because, I'm sorry, I'm not going to legislate how people live within their own homes. So that there is relatively limited scope for intervention. I'm not saying that there shouldn't be, because better building quality, better ventilation, and all of these are no-brainers. But in a way, there's somewhat lesser scope for, if you want, political and public health interventions than it is for outdoor air pollution. And actually understanding the impact, having the tools to appropriately ascertain it at an individual level, and then a set of measures that can make an impact. So indoor air pollution is I think much more complex an issue, given the sources of exposure and beautiful studies, sort of the healthy home studies in West London demonstrating this.
There's even the case of I think it's the Rosalie Foundation, if I'm not mistaken, right? That is kind of paradigmatic of really what the worst that can come out of poor indoor air pollution levels. And also I'd like to maybe just add, because I see Soterios in the chat, and I always try to give him a little bit of marketing, and going to Nikos's point as well. I think an important thing is I might not be able to understand the levels of pollution, right? I might not be able to understand what a certain level of P2.5 means, but we could come up with a system like we do for outdoor air quality, where we can just gauge in an easy way for somebody who's not a technical person what it means, right? Red is bad, for example. I know color coding as well. There's some issues with that as well, obviously, for people who have color blindness. But I think that's also an important point, interpreting the data for people who are maybe non-scientific, right, as well, but who are able to act from it as well. We had a few more questions lined up. I'm going to move to this one. I'm going to only do this one today, so then we can go to the questions. It's another word cloud. After that, what's the first action you will take to improve the air children breathe? So from all of these different perspectives, we have medical practitioners, we have policymakers. Could you say in 2 or 3 words what the changes would be? I'm not sure we've moved ahead here. Let us see. I think we are having some difficulties waiting for votes. Not sure, not getting any votes in. So if you could put one participant's being brave. But I'll go from Adnan now. From your presentation, from everything you've said, what would be the first action you would take today? I think I can guess it, but I'll let you say it.
Well, that's, I think as a profession, we are in a position to impact the lives of individual patients. So actually, sort of in that one-to-one consultation, you can make an impact for individual children, particularly when you ascertain potential problem. But also, I think we need to advocate for the change at population level, so to push for political change that would allow this to happen. So there isn't one thing we'll never do. Act sort of at that individual level, make sure there's increased awareness, but also sort of try to address it in more global term, hopefully with ultimately changes in legislation that would allow us to get to a position where kids are going to be breathing clean air.
So it's at the start, has to start at the top level. There has to be action at the top level, and then that has to maybe kind of seep downwards. Okay, and now Nikos, would you agree?
We cannot wait for politicians to do the things for us. I mean, so yes, political change is needed, but we have to act now.
So maybe both. So grassroots and the top level. Nikos, please, do you agree?
Yes.
Disagree? What do you think?
We are actually, we are calling our politicians to do many things nowadays. They are doing exactly the opposite. So anyway, but yeah, so the grassroots thing on what we can do is, you know, is here now. One thing is awareness, that's very important, and then you can actually go with the idea of the sensing. I think trying to understand what's there, at the same time trying to understand better the mechanism. So I think we need to realize that this is a stepwise approach. There's not going to be any policy either from top or the bottom that will actually magically change things in a way. We have produced tens of thousands or hundreds of thousands of chemicals. We have changed nature. We are being exposed to many things. If we want to change it, we need to take, you know, steps towards that direction. Awareness and understanding what's out there.
I'm hoping with the mission from these webinars that we can just do that, and we can empower people with the right resources, right knowledge to take action into their own hands. And maybe in the cases, right, where we need action from a higher policy level, obviously, we need to engage politicians there. So very strong call. Ivana, you have the closing word of this interactive bit. So what would you say? What would be the improvements that you would put? Do you agree, disagree with Nikos and Adnan?
I do. Well, actually, I agree with everyone, but I'm a strong advocate of education. I believe education is the basis for all social change. We need to educate the people. We need to educate the children. We need to raise awareness through education. But also I think we need to start looking at indoor air quality as a global social problem. So it's not just a local problem. It's not just a matter of environmental science. It's not just a matter of healthcare professionals. I think it's a global social problem, and I think we need to address it as that. We need to educate. We need to raise awareness, and we need to take air pollution and indoor air quality to the next level and start looking at it as a global social problem.
Thank you. I like that idea. We all deserve to breathe the same quality air. And it's a mission actually GoAQS. I'm going to do a little bit more marketing for Soteris as well. It's a mission that GoAQS is really trying to push ahead. And it's something I really agree with as well. We all have the right to the same clean air as we do water, for example, right? That's a human right that's etched out in the United Nations Charter of Fundamental Human Rights. We will now just have one question for each of our participants that came from the chat. Maybe we might have time for a little bit more. We will start with Adnan at the beginning. So you mentioned multiple harmful exposures can have additive effects on lung function. In the case of sudden removal or reduction of indoor air pollution sources, how quickly might we expect to see measurable recovery in the lung function among otherwise healthy adults? I'm going to put that question in the chat as well.
Yeah, we can extrapolate the data, but you've seen the Californian experience. It is very, very, very kind of quick impact that you have, particularly sort of on generations to come. What is very important, this sort of doom and gloom scenario, or if damage has occurred, it is very difficult to reverse it. Well, clearly, all of the data in last year would suggest very clearly that that is not the case, i.e., there is a scope for improvement at any age, at any time of development. The exact magnitude of that change will differ between different individuals, but the impact will be pretty much instantaneous. You're not looking here at decades, you're looking here at months to years.
It's okay. That's actually a very hopeful and optimistic look there. So action could lead to significant improvements in a short period of time. It's not something like you're saying waiting years, but something quick. Okay, that's a very hopeful message.
It's important to say it's not. It could. It would lead. It would lead. There is no doubt about that. The issue here is about willingness to intervene. And yes, we can quote Declaration of Human Rights, but human rights seems to be the last thing on mind in the current world. So
sadly,
any improvement in air quality will result in measurable improvement in health outcomes very quickly.
I like that very strong statement there. And yeah, just have to agree with you. Unfortunately, the world seems to be turning the other way, but that renews the importance of projects like ours, right? Obviously, they're not a panacea for the issue, but they support and they make improvements. And so strong message. So will, not could, but will. Nikos, now turning to you. Could you elaborate further on what is currently known about synergistic interactions between air pollutants, allergens, and other chemical agents in relation to health outcomes?
Yeah, it's a very nice question. It's actually the topic of a systematic review that we're actually running with Synergy. And one of the issues is that the extent is huge. I can give you a couple of examples of work that we have done in the past about, for example, synergistic interaction between viruses and allergens as irritants, actually. And we know, both practically and from our experiments, that if you get infected with some kinds of viruses, then you develop hyper responsiveness, which means that if you have something afterwards, then you would respond much more towards it. And this much more is actually synergistic. So it's not just the addition of these two elements. We have shown that in vitro. We have observed that in vivo. People observe it in everyday life, and also from some observations and from some experiments, that if you first get another type, so if you first get the irritant type of exposure and then you get the viral effect, then you don't get this effect. So this highlights the complexity. There are also some findings about the interaction between tobacco smoke and viral infection. There are some findings between, again, viral infection, allergen and pollutant. So there are many cases, but the types of interactions that induce synergy are under investigation to be able to describe exactly which setting. And actually what we're interested in is try to identify what you can take out from this equation. So what to take out, what to filter, what to clean, what to avoid in order to have the maximum effect, because it will come down to maximizing have the best effect, the best intervention out of cleaning everything. Because if you can clean everything, it would have been nice, but you wouldn't be able to.
Very interesting. And maybe you're saying there's some known unknowns, but maybe there's a number of unknown unknowns yet that we still kind of need to discover. A little bit scary, not gonna lie, but at the same time, I think it renews again the importance of the work that we're doing as the Ideal Cluster, as Synergy, as EDIAQI. And Ivana, it's a set of 3 questions, but they're all to do with the microbiome. I remember once Mario mentioning it's good to have a dog, actually. Now they used to tell you, no, it's not a good idea to have a dog, but now it's a good idea to have a dog. I've been telling my wife that, and she's not agreeing with that option. Okay, so how are you planning to integrate indoor air pollution data with microbiome profiles? Are there specific hypotheses about how environmental exposures might influence microbial diversity or function? And are there early signs suggesting that the microbiome might mediate or amplify the health effects related to poor indoor air quality? You touched upon it before, but yeah, let's go back to that.
Yeah, well, generally speaking, microbial diversity, greater microbial diversity is associated with health. We are integrating both the indoor air quality measurements and the microbiome data. As I said, there are preliminary results indicating that lack of microbial diversity in the households of the SIGROP pilot participants is associated with asthma and with allergy. Also, there are preliminary results. So these are just preliminary results. These are not yet being even written, let alone published, but these are just preliminary results that I got a few days ago. That certain kinds of microorganisms are really affected by certain pollutants, such as the polycyclic aromatic hydrocarbons, while others are not. So this may mean that greater indoor air pollution or greater levels of certain indoor air pollutants might favor certain kinds of microorganisms versus others. So this selective diversity is also associated, is known to be associated with different diseases, including respiratory and allergic diseases. So yes, I believe this agri-pilot will be able to offer, at least to a certain extent, this kind of information. And yes, we are integrating all of this data. And in the end, we will try to build complex prediction models that might be able to give some insights into the early development of allergic and respiratory diseases through the microbiome diversity.
It's, one time Mario had said, I think with 50% of our body mass might be the microbiome, which I was a little bit shocked to find out. But obviously it highlights the importance. We have very little time. I need to do some marketing. So in 10 words or less, maybe I'll give you 15, okay? Final words. We'll start again from Adnan, and then we'll go to Nikos and to Ivana. Adnan, 15 words or less, your closing statement.
I think the time to act has been yesterday, not today. We really need to act now in order to change what can be changed and influence what can be influenced.
Nikos?
Awareness, monitoring, and sensing. 3 words.
Very good, very concise. Ivana?
Alex, are you actually counting the words?
That one I could count. That one I could count.
Nikos, you could count. Me, perhaps not. Okay, so as I said in one of the previous questions, I believe that indoor air quality should become a global social problem. And it's clean, as you said, clean air should be a fundamental human right, and we should treat it as such. So educate, facilitate, and take it to a global level.
Very strong, nice words for the closing. Okay, some marketing now before we let you guys go. So please, Jan, I'm not sure if he's here, I hope he's still here. I saw he was on the chat. He created this survey. We're creating a monitor, which is basically a bunch of different sensors inside one device. Please take the survey. We want your views so that we can make sure it's really fit for purpose. Now you can join the EDIAQI. Well, actually, first you can join the Synergy community. That's the website. Just check out their website. They also have LinkedIn. We encourage you to become a part of our vibrant community by joining Synergy Project, the EDIAQI project community, and the broader Ideal Cluster community for seamless updates and information. So I'm just going to let it stand here for a little bit. Hopefully, you're going to have some people joining your community. Then we have the Ideal Cluster. Please join the Ideal Cluster community. I'm going to leave that here for 10 seconds. 1, 2, 3. Okay. And now EDIAQI. We went really crazy. We went for it. We have a lot of different social channels. Choose the one that you like most. Choose your favorite one. Okay, we'll leave it there for a few seconds. And okay. We extend our heartfelt gratitude to our panelists for their invaluable perspectives. Thank you, Adnan, Nikos, and Ivana. And to you, our audience, for that engaging discussion that brought the event to life. With that, we conclude today's session. Until next time, stay connected and informed, and wishing you all excellent air quality, both outdoors and indoors. Thank you, and goodbye.
Thank you.
Bye, everyone.
Bye.